So I wanted to just get the panel's thoughts. We have, again, cataract, we have glaucoma, we have an intersegment perspective. We've heard about, the combined cataract glaucoma market, which is currently the indication for the current MIGs device. Going forward, what are your thoughts in terms of how that develops and compared to the standalone market, which of course we talked about being a larger market, and how does that play into the clinic setting?
I guess I'll start. I think it's exciting. It's great to be able to perform MIG surgery in patients that are having cataracts removed, but there are a lot more patients out there that could benefit from it. Patients who are not compliant with their drops or can't afford the drops, or they have adverse reaction to the drops, and to be able to do a minimally invasive procedure and keep their pressure controlled, I think would be fantastic.
I think that Rick, from the glaucoma perspective, the glaucoma community has been a little bit cooler on MIGs in general in terms of the efficacy. What are your thoughts from the glaucoma surgery side?
Well, the glaucoma surgeons in general are a little slower to adapt than the cataract surgeons. So we recognize that, but I think that they've come around now, and I think that certainly the younger surgeons, the people just out of fellowship and residency are clearly adapting to it. One of the nice things about MIGs, it's directing the treatment at the problem. It's directing it at the meshwork. It's directing it in an area where we're not inducing significant external problems. I had a patient just a week and a half ago who calls me after 15 years after having a trabeculectomy. Calls me and late at night actually, and I said, well, come in first thing in the morning, and he'd had a successful bleb for years, good pressures, comes in with active endophthalmitis. And that existing problem with trabeculectomies is forever present. It's a time bomb waiting. And I think the MIG space is going to obviate all that. We're going to be dealing with direct tissue, and we're going to avoid those long-term issues.
Jay, from your perspective, again, being a clinician and also being on the industry side, how do you see this play out from both groups?
This is a great time. I think the days of polypharmacy and glaucoma and tubes and trabs are over. It's on life support. I think MIGs has done that. All the wonderful work done at Glaukos the last several years has really put us into the second inning of the MIGs ballpark, the MIGs game. And I think, quite frankly, to decouple the procedure from cataract surgery will allow us to intervene quicker and at an earlier time frame, and hopefully shift the whole disease curve to much earlier in the journey for glaucoma. So I think this is very, very exciting, and I do see decoupling the right direction to go the next couple of years. And we'll see how it pans out as all these new devices come to the market the next 18 months. It's very exciting.
So I want to just maybe talk about adoption, because I think it's a question that lingers around, is what is the market adoption going to be from a clinician side? You all have done mixed procedures, you're all great surgeons, but how will this be taken upon the general comprehensive ophthalmologist or the surgeon who maybe doesn't or is not as in tune to MIGs? You've all been to that learning curve. Your thoughts on this? Will that be a barrier, and what will the adoption curve be like?
Well, quite frankly, I'll tell you that in northern Jersey, New York area, we have a lot of glaucoma in our practice. I'm a cornea cataract surgeon, did a refractive surgery fellowship 17 years ago, and that said, 40% of my practice is still glaucoma. And I think we owe it to our patients to afford them the best in prostaglandins, combination therapies, SLT. But when we feel that they still have visual field deficits, they're losing their vision, and we have these options short of trab and tubes, why not? So I think surgical planning, I think journey planning for the patient is very important. And in our area, I was one of the very first surgeons to do MIGs, very excited. I made it look very easy with a learning curve. And when that happened, it resonated very quickly in the northern Jersey market. And now so many surgeons are doing MIGs. And the younger surgeons at New York Eye and Ear and all the training programs in New York, we're seeing so much robust energy towards getting to glaucoma because of MIGs, not because of tubes and trabs.
I have two thoughts on that question. In addition, I think that there's so much new technology going on in ophthalmology that it's really incumbent upon all ophthalmologists to keep up. And it's not just in glaucoma; it's cornea and cataract, and everything we're doing is continually evolving so quickly, so much faster than it used to, that I think that the doctors are going to be forced to keep up because they'll want to stay current. But secondly, I think they're going to get pushed by the patients. The patients come in now to our office having they go online. I've got glaucoma, and they go on Google and they see what the options are, and they want this. They're demanding it. And so you can't just say, well, no one's doing it, because they can go on the internet. The patients are much more aware, and they're going to force the issue.
Yeah, I think one of the important things, Ike, will be making it a procedure that is relatively easy to do, and the surgeon will believe is safe and he's not going to do any harm, especially if it's a standalone procedure. So, for instance, when I started in planning the eye stent, I had a little bit of trepidation because, yeah, I knew what the angle structures were, but it's been a long time since I went in and identified them, and certainly didn't play around with them during cataract surgery. So there was a little bit of a learning curve. And you were present with me in Chile when we put in some of the Hydra stunts. And I know you don't like the Geico commercials, but almost as easy as a caveman could do it, you know? It's got to be safe. It's got to be fairly easy for the surgeon to perform, and so that surgeon has to have confidence that they're going to do a good job without causing any problem in the eye.
Great. Well, I know that we're a little behind in our program, so I want to thank our panelists for a great discussion. Thank the company presenters. I think MIGs is really alive and well, is growing. Stay tuned. The place is getting pretty crowded, but I think the future is quite bright in glaucoma surgery. Thank you.